Does optimal health always have to be a choice between lifestyle or medicine? Or perhaps should the conversation actually be lifestyle and medicine whenever needed? Tonight, our special guest is an interventional cardiologist who will help us understand the nuance of that conversation. Lifestyle and medicine, a comprehensive heart defense is our topic tonight, and we are thrilled to have as our guest Dr. Heather Shenkman to help us understand that there is room for both. Good evening, everyone. I'm Jim Spellos from Planned Metro New York, and along with my colleagues, Judith Zerden and Ben Mertens, we welcome you to another episode of Heart to Healthy Heart, plant-based conversations that can save your life. As always, we encourage you to use the chat box to tell us where you're viewing from, as well as ask any questions of the doctor. And we will try to get to as many of your questions as our 30-minute time slot can accommodate. But now let me introduce tonight's very special guest. Dr. Heather Shenkman is an interventional cardiologist in Tarzana, California. She's the author of the Vegan Heart Doctor's Guide to Reversing Heart Disease, Losing Weight, and Reclaiming Your Life. Now, while she is skilled at a lot of invasive procedures, Dr. Shenkman is a strong advocate for a healthy lifestyle, including plant-based eating and regular exercise. She's an avid athlete, having completed 2 triathlons and century cycling events, swim meets, marathons. So let's just bring us all onto the show. Dr. Shenkman, now we want you front and center. Thank you so much for being here tonight. It's a pleasure to have you.
Hi, thanks for having me. Can I just correct one thing in the bio? I may have made a typo, but I've done more than 2 triathlons. I've done 2 Ironman triathlons, and I've done like about 100 triathlons of various distances.
Wow. So where do you have time to practice your cardiology? Or when do you have time? Oh, perfect. Well, why don't we start with a very basic question, because you are an interventional cardiologist and one who's a preventive cardiologist. So for everyone out there, what's the difference and how do they both support how you treat and help all of your patients?
It's a great question. So interventional cardiology, which is a specialty that I specifically trained in, is a field of cardiology in which we can use invasive procedures to improve heart health, open blocked arteries, and in some circumstances, fix abnormal heart valves and structural problems of the heart. In particular, the part of interventional cardiology that I focus the most on is coronary interventions. So in the setting of somebody who's having a heart attack, I can go in and open up a blockage and literally save a person's life and decrease the amount of long-term damage that would have been done to their heart by that heart attack. That said, the vast majority of the procedures that I do on the heart, I mean, much of what happens to people's hearts is preventable. It is said that 80% of all heart disease is preventable by diet, exercise, and lifestyle choices, which is why I like to combine both my passion for prevention and my procedural skills as an interventional cardiologist. And even somebody who I'm meeting for the first time in the setting of their massive heart attack, I'll finish my procedure. I'll talk to them, say, we're done with the procedure. I opened your blocked artery. So now we need to talk about your lifestyle going forward. We talk and say, how are your eating habits? Do you know about plant-based diets? Do you exercise? Do you smoke? And then those are things I reinforce throughout the patient's hospital stay.
Okay, so hi, Dr. Shenkman. How are you?
I'm great.
Good to see you. So So when we're talking about reducing the risk of heart disease through lifestyle, we're generally referring mainly to a type of cardiovascular disease called coronary artery disease. But of course, there are many other types of heart disease. And I want to make that distinction, if you could just clarify it for our listeners, because not all of them are as amenable to dietary and lifestyle modifications.
No, I absolutely agree with that point. There are a lot of diseases of the heart that I do treat. So, for example, there are congenital diseases. So, in other words, things that people are born with. You can be born with a structural abnormality of the heart, an abnormal valve of the heart. There are arrhythmias as well. I mean, there are a variety of things. There's congestive heart failure. But that said, that lifestyle does have some form of background in most of those things. That said, even people who are born with an abnormal structural heart, who may have what we call congenital heart disease, those are people who may do very well for years to come, but they can still succumb to the other, issues like coronary artery disease. There is an arrhythmia of the heart called atrial fibrillation that is fairly common, and it is a rhythm issue, but it also actually is much provoked by lifestyle as well. So lifestyle does play a role in heart disease beyond just coronary artery disease.
Thank you. Yes. Ben?
Good evening, Dr. Shenkman. What are the modifiable risk factors for coronary artery disease?
Excellent question. I'll start with the non-modifiable risk factors. So the things you cannot change. You cannot change your genetics. So if you are predisposed towards coronary disease based on the genes that you were born with, you have that to work with, but that said, doesn't mean you're destined to get heart disease at a young age. So genetics and gender and age. So you can't change your age, you can't change whether you're male or female. Men tend to have heart disease at younger ages than women, particularly before menopause. Once women hit menopause, we tend to, for the most part, catch up to men in terms of our risk for heart disease. But the things we can modify, and it's a long, long list. Again, 80% of heart disease can be prevented with lifestyle. So number one, smoking. That is really low-hanging fruit. If you're a smoker and you can quit smoking, I know it's hard to quit smoking, but that really is like the number one thing that anyone can do to reduce their risk of heart disease. Diet, eating a healthy diet, a diet that is more plant-powered as opposed to what we consider to be the standard American diet that has a lot of animal products and refined sugars and processed foods. Exercise, getting movement, not only necessarily in daily living, but also finding time to get out and doing exercise. The recommendation is a minimum of 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise per week, though more than that is actually better. Stress, managing the stress in your life is also important for reducing your risk of heart disease. Also controlling your risk factors. If you have high cholesterol, making sure that that is under good control. If you have high blood pressure, making sure that is under control. And if you are a diabetic, making sure that your blood sugar levels are at appropriate levels and your hemoglobin A1C, which is a measure of blood sugar over a period of 3 months, is at an appropriate level.
High blood pressure. What causes high blood pressure?
High blood pressure is caused by a number of things. There are some genetic predispositions towards high blood pressure, but also lifestyle as well. So smoking, a diet that is high in sodium, that is higher in processed foods, carrying more body weight, obesity predisposes towards high blood pressure, lack of exercise, also smoking. But that said, also as we get older, the arteries tend to be stiffer, so blood pressure can go up as we get older as well.
So how do you, if somebody comes to you with high blood pressure, you just laid out a lot of the very interesting ways, their risk factors for high blood pressure. but would you start generally with asking them what their lifestyle is before prescribing medication, or do you go right to, I guess it depends on the severity of the blood pressure problem, but how do you integrate both lifestyle and blood pressure medicine into your practice?
I think that's a great question, because I think that both lifestyle and medication can be very important in helping somebody to control their blood pressure. But I really honestly start the conversation with lifestyle. I want to know where we're starting at. Is this somebody who's exercising? Is this somebody who cannot exercise because they're having chest pain, because there are consequences of uncontrolled high blood pressure, like coronary artery disease, that I really need to evaluate for when I'm first meeting somebody. I want to know what their diet is, if they're getting their meals at home, if they're eating at restaurants, if they're eating a high sodium diet, if they're eating a lot of junk food. If they're a smoker, if they are vaping, if they're using drugs, if they are drinking alcohol. Alcohol drives up the blood pressure, particularly consuming more than a couple of drinks per day, and binge drinking as well. You go out on the weekend and you're consuming several drinks at a time. Even if you're not drinking the rest of the week, that is going to be something that raises your blood pressure and is not good for your overall health either. So I like to incorporate both the lifestyle and the medications. Some patients who come to me who may have high blood pressure and they're not on medicines yet, I'll frame it to them this way. I'll say, there's two ways that we can do this. We can either optimize your lifestyle, or we can start adding some medicines. And most people don't want to take more pills. So they say, okay, what can I do? And so we'll lay it out. We'll think about what types of lifestyle changes are possible to achieve. And then I'll have the patient follow up with me in maybe a month to 2 months. We'll see how the blood pressure is at that point. If the blood pressure with an ideal lifestyle doesn't get to where it needs to be, then we talk about medications. Being on medicine for blood pressure, it's not the end of the world. But even in spite of a really good lifestyle, I've got a lot of, because I'm the vegan heart doctor. That's how I've labeled myself on my book and on social media. I get a lot of patients who are on plant-based vegan diets who actually, have really good lifestyles. They eat very well, but in spite of all of that, they've got high blood pressure, and medicine may be what's needed to lower blood pressure. The problem with having high blood pressure that is not treated adequately is that it is what we call the silent killer. And it does increase your risk of having a heart attack or a stroke over time if blood pressure is not controlled. So if I'm going to be adding medication, we have a long conversation. We figure out which medicine is going to be best for this person. I don't like to layer on a whole bunch of medicines at once. I might start with one combination pill that's got a little dose of 2 different things. And I like to follow patients up pretty closely. So if I add on a blood pressure medicine, I want to see them within 2 months to see how they're tolerating the medicine, if they're having side effects, making sure that if it's something that's going to affect their kidneys or electrolytes, that we're doing blood work. And I always make sure that the conversation is open. If there's any side effect, any problem that is perceived with the medicine, I want to hear from my patients, and I tell them unequivocally, if you feel you cannot take this medicine, you call me before your return visit.
I love your approach. I have another question, Ben. What is the goal of blood pressure that you're trying to get your patients to, either with lifestyle or with meds?
Sure. That's a really good question. So for people who are under the age of roughly 70, if we're treating somebody for high blood pressure, we are aiming for a blood pressure of 130/80 or less. In general, a blood pressure of 120/80 or less is considered normal. A blood pressure of 130/139 systolic, that's the top number, over 80/89, that is considered stage 1 hypertension. In those people who have no risk factors whatsoever, they may be relatively young and have good cholesterol numbers and not have any problems with their arteries, and they may not a diabetic. Those are people who I think we can not treat until their baseline blood pressures get to 140/90 or higher. That said, as people get older, lowering the blood pressure can have consequences. So people who are in their 80s and 90s actually may need a little bit more blood pressure to the brain. And there is the risk that if you're lowering blood pressure, you can precipitate falls. So in those patients who tend to be older, we're a little bit more liberal in our treatment. We'll tolerate blood pressures that are higher. For example, I had a woman in my office today who is 94 years old, who I'm treating for high blood pressure. And her blood pressure at times dips into the low 100s, and when it gets that low, she's actually had falls. So I actually took her off of a blood pressure medicine today so that we could try to get her blood pressure a little bit higher. Somebody in their 90s, I might tolerate blood pressures in the 150s or 160s, because when we get older, there's probably a little bit more harm that there's probably more harm that can come from the blood pressure being too low than it can from being too high. Because God forbid your blood pressure is too low, you fall, you break your hip. I mean, that can be absolutely catastrophic.
Dr. Cholesterol, what exactly is cholesterol?
Cholesterol is it's a fatty substance that's in our bloodstream. It has function. We need it for brain function. But that said, our bodies make way more than we need. So where do we get cholesterol from? We get it from our diet, either by eating foods that have cholesterol in them, namely animal foods, or from eating foods that cause our liver to produce more cholesterol, particularly fried foods and processed foods, which will raise our cholesterol levels. Now, the higher the cholesterol, the higher the risk of plaque in the arteries, the higher the risk of heart attack and stroke. And there is definitely a relationship between that. That said, as we lower cholesterol numbers, the lower the cholesterol, the lower the risk of heart disease and stroke.
What are ideal cholesterol numbers?
What are ideal cholesterol numbers? That's a good question, and that really varies person to person. I think for somebody who has no cardiac risk factors, I think that an LDL cholesterol ideally should be less than 100. The HDL, which is the so-called quote unquote good cholesterol, that is actually a lipoprotein that circulates in the bloodstream and actually kind of does cleanup and gets the extra cholesterol molecules out of the body. The higher that is, typically the better, as long as it's not too high. So for women, we like to see the HDL cholesterol be greater than 50, for men, greater than 40. That said, that HDL cholesterol level is for the most part genetically determined. It improves a little bit with healthy lifestyle, with healthy eating, quitting smoking, but doesn't typically budge much. The numbers that we know are actionable that will help reduce risk mainly is LDL cholesterol, but also triglycerides.
Okay, so actually, just to follow up about the HDL, we've spoken with some other doctors about HDL, and they've said that, on a plant-based diet, HDL will generally decrease, and people shouldn't worry too much if that happens, because, it did happen to me, actually. Now it seems to have gone back almost to where it was, but, is that a problem? Or I think the way they explain it is if your LDL is lower, you don't need as much HDL to transport the LDL cholesterol.
Right. There may be something to that, but yes, no, I agree. And it's definitely something I've observed in my patients who've gone plant-based, is that with eating a whole food plant-based diet, the LDL cholesterols will drop dramatically, but the HDL cholesterol will also drop a little bit. Is there any consequence or harm to that HDL cholesterol dropping a little bit lower? Probably not. I think the benefits of a whole food plant-based diet, or leaning more in that direction, I think outweigh that small drop in HDL.
That's really the question that I was supposed to ask you about, how eating a whole food plant-based diet affects cholesterol, and mainly in a beneficial way. So can you talk a little bit about that?
Yes. So a whole food plant-based diet, which is a vegan diet that is minimal in processed foods, that will lower the LDL cholesterol. It should lower the triglycerides, and it may lower the HDL just a little bit.
Thank you.
Who
Ben?
should be on a statin?
Who should be on a statin? That is a not the easiest or most straightforward question. In the past, if you had asked, 20 years ago, the guidelines of our societies were if your cholesterol is above X number, you should be on a statin. And it was as simple as that. But the answer is, quite frankly, a little bit more nuanced than that. I'll start with who absolutely should be on a statin. So American College of Cardiology and American Heart Association states clearly that anybody who has arterial disease, who has had a heart attack or stroke, it is a class 1 indication to be on a statin regardless of your cholesterol levels, because we know that if you have already had a heart attack or stroke, or you already have arterial disease, you will reduce your risk of having a heart attack or a stroke with a statin medication. That is going to be something that's fairly powerful. It gets a little bit more gray in other areas. We do strongly recommend statins as a class 1 indication in anybody who has diabetes, whether it be type 1 or type 2, who's between the ages of 40 and 70, because diabetes is a big risk factor for heart disease. Also, for anybody whose LDL cholesterol is greater than 190. And the reason for this is that when we see LDL cholesterols that are over 190, this is not necessarily somebody who's got a terrible diet. It may be, but typically it's because they have some sort of genetic predisposition, particularly something called familial hypercholesterolemia. They have a gene for this that causes their body to produce more cholesterol. And regardless of the reason why you have more cholesterol, the risk of heart attack and stroke in the long term is significantly higher if LDL cholesterol remains, 190 and higher over the course of many years. So these are people who should be on statin medications or something to lower the cholesterol. It gets a little bit grayer in other areas. We actually have risk calculators, so we can use numbers like your HDL, your LDL cholesterol, your age, your blood pressure. We can actually calculate what your risk of having a heart attack or a stroke in the next 10 years is. And using that number, that can help to guide us as to whether you should be on a statin. Our societies suggest that somebody who's got a 7.5% risk over the next 10 years, that's considered intermediate risk. That's a pretty reasonable threshold for starting a statin. That said, it's a conversation. It's not it's not me saying you need to take a cholesterol medicine. We have a conversation. We say, so this is what your risk is. If you take a statin medicine, you will reduce your risk of heart attack and stroke by a modest amount. But that said, it's a medicine you're taking every single day. It's going to be a long-term medicine. Most people tolerate them very well. There's 5 to 10% of people who will have myalgias, also called muscle aches, that are associated with the statin medicines. They are not it's not a long-term side effect. We stop the statin, the myalgias, muscle aches tend to go away. More often than not, we can find a statin medicine at a different dose, a different type of statin, or even maybe a different kind of cholesterol lowering medication if we need, that a person will tolerate to help to reduce their risk.
We have a couple of minutes to go, but the question did come in from one of our audience members, a little bit more advanced, but the question's about what do you think about getting advanced tests such as Clearly? And she indicates that as AI-enabled analysis of coronary computer tomography angiography. So tell us about that.
So that's an interesting question. So one thing I did not talk about, and this is somewhat along those lines, is a coronary calcium score. It's not an AI test. It doesn't involve injecting contrast dye like the test that you talked about. So it's a very quick and very simple CAT scan that counts the amount of pixels of calcium in the arteries of the heart. And from that, you get a score. If your score is 0, that means you have no calcified plaque in the arteries. It doesn't mean you have no plaque, but it means you have no calcified plaque. If your coronary calcium score is 0, your risk of having a heart attack or stroke in the next 5 years is close to 0. So you're somebody who's very low risk, and that's somebody who we would really probably not put on a statin medicine, because a statin medicine is not going to make a big difference in terms of reducing risk if your risk is already very low. If your coronary calcium score is 100 or higher, that indicates some risk. And if your score is 400 or higher, that really suggests high risk. Our societies suggest that anybody who has a coronary calcium score greater than 100 is somebody who should be on a statin for prevention of heart attack and stroke. As for CT coronary angiogram, I think that was part of the question. I don't know about the AI part of it. Certainly not something we're using in our daily practice at this point in time. But a CT coronary angiogram is a CAT scan where we can inject a dye into the arteries, into a vein, and it will opacify or make clear what the arteries of the heart look like. We can do a CAT scan and get a rough idea of how much actual plaque a person has. Which can further guide treatment. But that said, it is a test. It involves radiation. It involves injecting contrast dye, which can have impact on the kidneys. So it's not a screening test, but it is something that we can use in our workup of somebody who we may have concern about.
We have a few minutes to go, so let's get a couple last questions on exercise and nutrition. Jude?
Okay, so yes, so I'm sure this is one of your favorite topics, exercise, and I know it's very valuable, but if you could just sort of give us your doctor's perspective on the value of exercise in supporting optimal cardiovascular health.
Exercise is a very important part of supporting cardiovascular health. It is recommended to get at least 150 minutes of moderate intensity exercise over the course of a week, or 75 minutes of high intensity exercise over the course of the week. Moderate intensity exercise being basically a brisk walk. That said, doing more than that is even better. And exercise is very potent at reducing risk of heart attack and stroke, lowering cholesterol, lowering blood pressure levels, helping to control diabetes. It's even good for mood and for memory as we get older. So exercise is something I emphasize to all of my patients. Even not just formal exercise, but just finding ways to move in daily living, like getting out and gardening, like walking from the parking spot that's in the back of the parking lot, just finding ways to have opportunities to move more in daily living.
Thank you.
What type of exercise is most beneficial?
I think the type of exercise that's most beneficial is the type of exercise that someone enjoys and they're going to stick with.
What about resistance training?
I think that there's definitely a role for resistance training. Cardiovascular exercise, I think, is very important. Just doing stuff that's going to get your heart rate up. Resistance training can get your heart rate up as well. And I think it is important to try to incorporate that, strength training, weight-bearing exercise to help to build muscle, because this is important for as we get older, for maintaining our balance and maintaining bone health.
Can exercise harm the heart because it causes oxidative stress?
Can exercise harm the heart? Yes, it can. There is actually evidence that people who exercise perhaps too much, and we're talking about like way more than what like the average person does. We're talking about people who do years of like long distance cycling where they're going out for 6 and 7 mile bicycle rides and competitive rides multiple days per week. People who are ultra athletes, ultra runners, and ultra cyclists actually have a 5-fold increased risk of atrial fibrillation over time. They also have an increased risk of coronary calcium, but that said, that actually hasn't borne out to suggest that they have an increased risk of heart attack and stroke, just more calcium in the arteries.
Yeah.
Judy, one last question.
Sure. Do you have any nutritional hacks for reducing risks of cardiovascular disease, like things that you would say to your patients, why don't you do this or that?
I like to keep things attainable. I mean, I don't have a bunch of like people who are vegans or vegan inclined who are necessarily coming to me. I mean, I get patients all across the board. People who eat fast food for every meal, who eat meat at every meal. So I try to keep things attainable. Finding like maybe if there's 1 or 2 fairly basic steps that somebody can take to improve their health. So if somebody like eats restaurant food every day for lunch, a good goal for them might be, why don't you pack a lunch and bring something from home 3 of those days of the week? Bring your leftovers from the night before, pack a quick salad in the morning or a quick sandwich. I think small changes that are attainable can go a very long way.
Yeah, thank you for doing that. I mean, most doctors don't even go there, so that's great.
And that's a perfect way to end the show tonight. Dr. Shenkman, the half hour just flew by. And what I want to be able to do is say thank you so much on behalf of Ben, Judy, and myself and the entire community for what you do and all the people you help so they can live their optimal lives. So thank you so much for being here tonight.
Thank you for having me. This was a great conversation.
Fantastic. And we want to talk about right now, next month will be Plant Powered Metro New York's 3rd annual Plantathon. This year, it's going to run over 2 weeks between the 13th and the 28th of November with both live and virtual events. And as part of Plantathon 23, Heart to Healthy Heart is completely honored to have joining us Dr. Joel Furman on Thursday night, the 16th of November. 7 o'clock Eastern Time. As always, if you want to watch any of our episodes again, they are all on the Plant Powered Metro New York YouTube channel. On behalf of Judy and Ben, I'm Jim, as always, wishing you optimal health, and see you next month on Heart to Healthy Heart.